Good morning, ladies and gentlemen. In spite of being nervous, I thank Steffi Czerny very much for allowing me to share with you some of the ideas that became actually a true passion over the past few years. We often hear, I should share this with you. Yes. We often hear that big data and AI may jointly revolutionize healthcare. And I of course, do share the enthusiasm about AI, and I couldn't agree more with what we heard this morning from Fabian Theis, one of the leading figures, if not the leading figure in this field. And I think we can be very proud to have him here in Munich and in Germany. So I couldn't agree more with him about what AI is going to bring for healthcare. Nevertheless, having said that, I would caution that AI can only be as good as the data are that are used for training it, which actually Fabian also mentioned. And the bad news is that, unfortunately, the available data are just not good enough for shaping the future of healthcare, which is supposed to be preventive. The reason is very simple, because the majority of the data that have been collected so far, which are available in the databases, have been collected at a symptomatic stage of the diseases that future preventive care should spot long before symptoms manifest. Comprehensive data acquired at early pre-symptomatic stage are in desperate need, with methods that are affordable at a population scale. This challenge led me to conclude my Nobel lecture with the question, what is the most economically viable set of health data that enables comprehensive and dependable monitoring of human health? Before I'm trying to explain how we wish to answer this, I would like to thank, even if it takes a few seconds of my time, I would like to thank the politicians and taxpayers of Germany for having made this country the Mecca of fundamental research and having preserved this status even through most challenging times like we are living for a few years in, as well as the politicians and taxpayers of Hungary for trying to follow the example of Germany. Owing to their support, we can seek the answer to this question with our team in Budapest and Szeged in Hungary, and our team in Garching by München in Germany. An affordable preventive care that captures severe diseases in their earliest stage of development is an overwhelming challenge. An overwhelming challenge that, if at all, can only be met in an international effort. That's why we triggered a global initiative that we dubbed Protecting.Health. Actually, this is also the website of the initiative, which was open today. Because the problem to be addressed is global. Every year, 17 to 18 million people under the age of 70 die of, and many more lose their ability to work due to non-communicable diseases, briefly NCDs, with the 4 most prevalent ones being cancer, diabetes, cardiovascular, and chronic respiratory diseases. Most of them are preventable, would be preventable by early detection. The tremendous loss of life and life quality and the loss of immense resources. In Germany, some 7% of the GDP, about 300 billion euro year by year, more than 4,000 euro per capita year by year. Implied by late diagnosis of chronic conditions, all these losses can only be mitigated by preventive care, which is able to catch the most prevalent killers in their early stage when treatment is much less expensive and has a much higher success rate. But equally importantly, this care must also be affordable, an enormous challenge. But we have a ray of hope owing to a key hallmark of being alive, homeostasis, a process that keeps our organism within the range of favorable or even ideal internal conditions. As a result, the molecular constituents of human blood are regulated within narrow person-specific concentration ranges around their homeostatic value, around the equilibrium value in the healthy organism, to maintain proper functioning of the organism. Chronic diseases may systematically up or down-regulate many molecules of human blood. An assumption that underlies our hypothesis that human blood is likely to carry the molecular information needed for comprehensive screening for NCDs, and prompts the question whether physical technologies can access a range of molecular signals responding to NCDs sensitively enough to capture them at an early stage to allow timely interventions. More careful considerations actually make us realize that this question is incomplete. If I have to be honest to you, this question is plain wrong. In physics, we know that the success of a measurement depends not just on the signal, but it depends on the signal to noise ratio. Therefore, reducing the noise is equally useful as increasing the signal. In contemporary one-size-fits-all healthcare, the noise is dominated by the heterogeneity of controls, the variability of homeostatic values, of the equilibrium values of all the molecular levels in healthy individuals. But perhaps this biological noise can be suppressed by a more advanced healthcare modality. The right question, and every good research starts with the right question, the right question, therefore, reads as follows. Can physical technologies and a suitable healthcare modality access NCD, non-communicable disease-induced molecular signals that exceed biological noise in the pre-symptomatic stage for early detection? Contemporary laboratory medicine captures molecular levels one by one, as you all know, which is apparently not really scalable to hundreds, let alone thousands of molecular parameters, and compares the measured values with population-based reference ranges, which are inherently ill-defined due to the large interpersonal variations. Future preventive healthcare calls for a revolution on both sides. For physical technologies that, instead of measuring molecular parameters one by one, are able to access hundreds or possibly even thousands of them in a single measurement, and for a healthcare modality that, instead of referencing to other individuals' values, allows to use our own previously measured values as a reference. These are the revolutions that we wish to bring about with our Protecting Health Global Initiative for creating the foundations of precision that is individual-based preventive care of the future. Our multimodal phenotyping approach unites two physical technologies pioneered by Germany. Actually, I should say here, I think I'm allowed to say it in this very room at this very location, pioneered more precisely in Bavaria. Cross-molecular infrared electric field resolved molecular fingerprinting developed by our group, and mass spectrometry-based proteomics pioneered in Matthias Mann's laboratory just at the other end of the U6 underground line. If these extended with metabolomics and lipidomics together will access an unprecedented amount of molecular information in human blood. Let us now consider one of the accessible molecular variables that is highly stable over time in a healthy organism. That means that these green points showing the value along the vertical axis vary just a little when they are measured repeatedly, as it is done here. This high temporal stability implies a narrow person-specific reference range, depicted here by this green stripe, way sharper than the spread of the same variable in a healthy population, depicted by the gray stripe. If this parameter is sensitive to the development of a particular disease, it increasingly deviates from the person-specific healthy baseline, the green stripe, with progression of the disease, and may provide first indication about the unfolding disease long before symptom-guided healthcare can diagnose it. Detecting disease before symptoms manifest requires you to donate blood repeatedly whilst you feel perfectly healthy. We need to repeatedly recall individuals to establish their personalized reference range and then following them up for capturing slowly evolving chronic diseases at the early stage of development and signaling risk for sudden events like a stroke or a heart attack. Precision prevention relies on person-specific reference ranges. Please take this with you, then this 25 minutes that you spend with me was not in vain. Precision prevention relies on person-specific reference ranges, which can only be acquired by repeated measurements within a short period of time, and afterwards upon frequent recalls to capture unfolding conditions at the early stage. We refer to this new study design, meeting all these requirements, as a longitudinal cohort study with repeated baseline and high-frequency follow-up. Briefly, the Protecting Health study design. The prototypical Protecting Health study was initiated by our Center for Molecular Fingerprinting in Hungary more than 5 years ago, with a target cohort size of 15,000 participants, aged above 40. We have meanwhile recruited more than 12,000 subjects, from whom our team collected more than 73,000 blood samples. This is the very first large-scale study all over the world that enables the robust evaluation of person-specific reference ranges, along with their evolution for healthy aging of all accessible molecular parameters of human blood, out of which we aim to find those with smallest within-person variations, just very little deviation around the dashed line, very narrow person-specific baseline, indicated by the green stripe, and have the strongest response to one or more prevalent NCDs. For some 5 years, I have been showing this conceptual slide to audiences all over the world. At last, I can now show that this is more than just a concept. In our prototypical Protecting Health study in Hungary, first participants have been diagnosed with NCDs after they had donated blood at least 6 times in our study, 6 times before diagnosis. Their blood samples have opened the door to the systematic scrutiny of the predictive power of blood plasma parameters, in our case, such as infrared molecular variables. Here you see how the ratio of selected spectral amplitudes of the infrared light emanating from the excited plasma samples of a study participant diagnosed with thyroid disease almost 4 years after enrollment in our Hungarian study evolves over time before diagnosis. The spectroscopic variable, this ratio of the two spectral amplitudes indicated on the left-hand side, exceeds the Persis normal range 2.4 years earlier, most probably in a symptom-free early stage of the disease. Here you see another variable's response to the development of a lung disease. The first red flag appeared here only slightly less than a year before diagnosis, but the great deviation from the normal range at this time actually indicates that the parameter might be able to signal the onset of the disease, most probably by more than 1.5 years before diagnosis. This actually also suggests the need for more frequent recalls. And indeed, we changed the protocol in Hungary meanwhile. And after the fourfold repeat of the baseline, right in the first year, we now recall participants twice a year. If we would have done this earlier, probably we would have this red flag half a year earlier. Twice a year. And we'll actually also do so also in the other protecting health studies to be rolled out soon. Yet another variable appears to provide first indication for the increased risk of the onset of a cardiovascular condition 2 years before the actual condition was diagnosed. Last but not least, yet another infrared variable is signaling the development of type 2 diabetes in the plasma sample series of a study participant 2.3 years before diagnosis, most probably at the stage of prediabetes when the disease is still reversible. These are just preliminary results. First results of 8 years' efforts exposed for the first time to an expert audience. They reveal the first candidates for pre-symptomatic biomarkers, which may enable cost-effective early detection of prevalent NCDs. But candidates are not yet biomarkers. To be able to remove the question mark here, we need at least several dozen, better several hundred new onset cases of the same disease to render the candidates a true pre-symptomatic biomarker for the condition. For many severe conditions, the cohort in Hungary will not yield a sufficient number of cases, nor does it represent all ethnicities. That's why we took the initiative of expanding the project that started in Hungary to other countries and actually even other continents. In a first step to Hong Kong, and hopefully in a second step, hopefully very soon, to Germany, to collect altogether more than 40,000 individuals' blood sample series consisting of at least of a minimum of 12 samples, hopefully even more. The majority of them will stay healthy with their samples, allowing to identify the most stable molecular variables and the evolution of their homeostatic value with healthy aging. These homeostatic values may slightly change just by us getting older. A significant fraction will contract prevalent NCDs with their samples, contributing to the discovery of pre-symptomatic biomarkers in blood plasma. The prototypical Protecting Health Hungary study will reach 1/4 of this target within a couple of years and more than 1/3 of this target by 2030. I joined the University of Hong Kong as a part-time chair professor last fall and built our Protecting Health Hong Kong team, which is now about to initiate the study in cooperation with the world-renowned Clinical Trial Center of Hong Kong U, with the first subjects to be recruited early August. Last but not least, we have proposed to the Bavarian government, represented here by State Minister Markus Blume and by Minister President Markus Söder, the foundation of the Center for precision prevention at the LMU, which in cooperation with Europe's leading institute of laboratory medicine at the Klinikum Großadern of the LMU could roll out the study in Germany, and we hope to be able to do this soon. Of course, in cooperation with Matthias Mann's group and with Fabian Theis' group, we have really world leaders here in this consortium. The three institutions, CMF, HKU, and LMU, have signed a strategic cooperation agreement to join forces for developing a screening algorithm for a range of prevalent NCDs. To this end, they agreed to contribute half of the volume of each collected sample along with pseudonymized health data, of course equally importantly, to the Protecting Health Biobank and database to be accommodated at a central unit where the multimodal phenotyping of the collected samples will be carried out and the joint analysis of the results and their use for algorithm development will be coordinated. To this end, we have founded the Protecting Health Limited Company based in Munich to attract private investment for contributing to the success of this endeavor in the framework of a public-private partnership with the big, bold aim to develop the first screening algorithm in the world, the PH 1.0 for early detection of prevalent NCDs. The emerging IP will be shared between the central unit created and operated by private investment and the sample collection carried out by public institutions, once again in a private-public partnership. Finally, let me briefly recapitulate the roadmap. Thanks to the unique Protecting Health study design, our participants will donate blood 4 times within a few months, right at the beginning of the study. This will allow the selection of molecular variables that are highly stable over time, very narrow green stripe, implying the narrowest possible person-specific reference ranges. These are the primary candidates for personalized preventive care. Over the subsequent 4 to 5 years, the development of prevalent non-communicable diseases, NCDs, will change the distribution of those variables, change the value of those variables that are up or down regulated by the onset of these common conditions, uncovering the best pre-symptomatic NCD predictors among the accessible molecular parameters. Whilst the blood sample collection is continuing, the profiling modalities will be optimized for these selected pre-symptomatic NCD predictors for sensitivity and throughput, and hence for minimized costs. This must, at the end of the day, be affordable at populational scale. Otherwise, this remains academic research. All these steps can be accomplished. All these steps can be accomplished in the absence of clinically diagnosed new onset cases. While those diagnosed cases can accumulate over the years to eventually allow establishing causal links between outcomes and parameter changes. With these links, an algorithm for detecting prevalent NCDs in their early pre-symptomatic phase of development will be trained and validated. This way, we aim to create the first comprehensive screening platform for prevalent NCDs, which we dub PH 1.0, for gaining actionable health insights into the major non-communicable diseases, including cancers, cardiovascular, respiratory, metabolic, and neurodegenerative disorders. At the earliest stage of their development, and here you see what the consequences of that will be, next generation molecular diagnostics. Dear potential sponsors and investors, to get interested in this project. You don't need to believe that the method we advocate for extracting molecular information will be the winning concept. You just need to believe that blood provides the necessary information. We built a repository, a biorepository of blood samples and accompanying health data that is second to none. That will be needed by any future technology that will try to pull out the necessary molecular information from human blood, whatever this technology will be. The repository that we built will be invaluable for creating the future of healthcare, preventive care. Thank you very much for your attention.